Hello, hi. I am Dr. Manoj Ayyappath. Welcome to my YouTube channel. I am an intestinal surgeon from Kerala, India. Today I am going to talk to you about or discuss to you about a topic called Achalasia Cardia. Achalasia Cardia is a very rare disease which happens in humans. So what exactly is Achalasia Cardia? You have this esophagus, just below you have stomach. So there is a junction between this food pipe, esophagus, and the stomach. So in the middle of it, the junction, you have a muscle, and the muscle, the function of muscle is to close and keep the food inside the stomach. But in Achalasia Cardia, this muscle is always closed. It is not opening when the food comes. So once you eat food, this has to open, and it's not opening, it is persistently closed. So that is Achalasia Cardia. So what will be the symptoms? Very simple. You eat food, it's not going down. So dysphagia, that's a primary symptom. The next is, once it is not going out, tries to comes out. So vomiting or regurgitation. That's the second symptom. So you start vomiting out. And third is, occasionally you have pain. So sometimes you have associated problems. What are the associated problems is, sometimes you vomit out this food, it goes to the lungs and producing lung infections. The recurrent lung infections, 2 times, 3 times or 4 times, it produces lung fibrosis. Your lungs start shrinking. At night you may have snoring, and sometimes you have persistent cough and hawking. So these are the few symptoms of Achalasia Cardia. It can happen both in males and females. So once you have these symptoms, what exactly you have to do? You have to meet a gastroenterologist. So the gastroenterologist may, once assessing the symptom, may submit you to a barium swallow. The barium swallow shows the persistently contracted the lower segment, and it will rule out diseases like cancer. But even with that, you have to do a endoscopy. You have to do an endoscopy as soon as possible. Once you put in what is endoscopy? You put a camera wire through your esophagus and see what is happening. In case of Achalasia Cardia, you will see the muscle always closed. In case of cancer, you can see the cancer and take biopsy of it. So once you think that there is Achalasia Cardia, the next thing you do is you measure the pressure there. That is manometry. The different kinds of manometers are available. Currently, high resolution manometry is the standard, and you classify Achalasia into type 1, type 2 and type 3. It's all more of academic and management issues. So type 1 is the commonest one, around 75 to 80% is type 1. Then you have type 2 and type 3. So once you classify this using the latest Chicago classification, you know what exactly you're dealing with. Once you're sure that it's Achalasia, what are the treatment options? The treatment options are few. One is injection of toxin, botulinum toxin there. So inject toxin there, the muscle, the nerves gets inhibited there, so the nerve supply is lost, so it starts dilating. So you can swallow. The problem with botulinum toxin is recurrence rate is high. It will come back again once the effect is gone. The next one is dilatation. You using endoscope, you put the endoscope, you dilate. So the problem with dilatation is, again, recurrence rate is high. Now the last two options are very gold standard options. Even currently the gold standard is keyhole. Using keyhole, it is Heller's cardiomyotomy. That's a surgery, laparoscopic Heller's cardiomyotomy, in which you put in a laparoscope, you divide this constantly spastic segment, you keep a cut there and try to dilate it. So laparoscopic Heller's cardiomyotomy is the standard. The other one is the POEM, per oral endoscopic myotomy. That is come up in a big way. So you put an endoscope. Through the endoscope, you make a cut in the esophagus, go down and divide the muscle. You choose only the circular muscles and cut it, so that the spastic segment is gone and you can swallow well. Peroral endoscopic myotomy is coming up in a big way as it's a minimally invasive. That is, it is lesser invasive than laparoscopic surgery. You put the endoscope and do. But the technical capability of doing peroral endoscopic myotomy are less. Many endoscopists doesn't know how to do it. So still, the surgeons do an excellent job. The results are definitely comparable. In fact, laparoscopic Heller's myotomy is a bit more better than a POEM. So because in a laparoscopic Heller's myotomy, after the surgery you add an anti-reflux procedure. So you cut the muscle so the acid may go up. So to stop that, you give a wrap around the esophagus, wrap around the food pipe. So you may add an anti-reflux procedure. So definitely Heller's got an upper hand. So these are the treatment options for Achalasia Cardia. The surgery is relatively safe and mortality rates are very, very minimal. So once you have these symptoms, you please consult a gastroenterologist. Thank you for watching my video. Please share this video for those who need to watch it, and please subscribe by pressing the bell button. Thank you once again.